I gave him a bronchodilator and his airway resistance went down. It changed in the shape of the flow volume curve. When we do pulmonary functions, that's what we're going to be doing. We're measuring each other's peak flows, and the peak flow is this peak right here at the dot. And then it should be a nice gradual drop down. If not, then I'm showing that the airways are closing as we're trying to exhale. But the graphics we use, the compliance, resistance, and you can see on these ventilators, for instance on this one, peak pressure, plateau pressure, mean pressure, peak. Compliance, resistance, sounds familiar. This one is 8 centimeters of water pressure per liter per second. It gives us both resistance inspiratory and expiratory. We have greater expiratory resistance than inspiratory. And we've got our compliance at 48 milliliters per centimeter water pressure. If I did something changes with my patient, now my curve went more upright and my compliance went to 64. So I can look at the graph and say, I know it went up. I look at the numbers and it tells me how much it went up. Now the one thing is, on this particular ventilator, it's not going to give me a static compliance, it gives me a dynamic. To get my static, I need to have a plateau. So it has here, and the plateau is, you see it come up to the peak on the pressure here. It holds for just a second and then drops down again. But it needs a solid one, it needs it over a period of time to calculate. So if I'm looking at it, I just look and say, okay, my plateau pressure is 12, my peak is 5, and my tidal volume is 500. So 12 minus 5 is 7. Divide that into 500, and I know what my plateau, my static compliance is. It will only calculate it over a long trend. Some of them will do one breath. The Drager does it on a single breath. It does a breath hold and then releases, and it only does it when you ask it to do it.
I got a question. Say if we want to find out their static compliance, does the monitors do that math for us, or do we normally do it like when we're in the field? Are we doing that?
Many times you're doing it in the field. Like in this case, as I said, it will not give me a compliance right now because it says I only calculate when you do a true breath hold, not a brief second.
And that's why we got to memorize those formulas.
Yep.
I put two and two together.
Then we'd have to go ahead and calculate. Say, okay, I know plateau pressure. Plateau pressure was 12, peak was 7, or 5. I know I have a 7. 500 divided by 7 is it. And you're always going to be rechecking them. This one will also not give me plateau. That one will. The one back over there does not. We have a couple others in the other room that do them as well. Some will calculate, some won't. Galileo does calculate on every breath. The problem is, people question is whether it's a true static compliance because it doesn't really do a breath hold. It does a slight pause, which is not really a breath hold as it should be. And in order to get a true static compliance, I have to have my patient cooperate. If I come in and say, just going to have you hold your breath here. Oh, yeah. Patient's not going to like it too much, and they're going to fight it. So anything more than about a 0.2 of a second pause, they're going to start bucking the ventilator. We don't want that, so therefore we look at it, do it quick, and then do our calculation and be done with it. But we have all these graphics come into play. Peak, the pressure volume curves, which are a compliance curve. We can do it with a static one where it gradually rises like we do with the Drager. Let me go back out of again, we have our graphics that we're looking at, plus our numbers. So the graphics are nice to look and say, okay, I need to look closer because that's what's changed. For instance, if my patient, and when we talk about PEEP, you notice the pressure here comes up, holds for the breath, comes down, but it doesn't come down to 0. And that is my PEEP level all the way across. When we talk about PEEP, that's what it is. PIP is up here. Now in this one right now, I have it in a waveform that doesn't have a plateau because it gradually decreases the flow. You see the flow comes up, goes down, and then holds with 0 flow, and then the patient gets to exhale. Because this one happens to be in a decelerating waveform, so there is no peak. Peak and plateau become the same pressure. So I only have one compliance then. But it also will go through my mean pressure, tidal volumes, minute ventilation. Minute ventilation it calculates for you. It does it combined. It measures spontaneous minute ventilation and mechanical minute ventilation. So if the patient's breathing more than I have it set for, it's going to tell me how much. In fact, it'll even tell me over time. I can look at trends on it, the data, and I can look at over the last 8 hours. What % of the breathing was done by the patient versus the machine? This particular ventilator also has a proportional assist. What I tell it that I want it to assist the patient, but as long as the patient's doing enough, just give them a little bit of help. Then when I look at it, I can do a graphic over the last 8 hours, or the last 2 hours, or the last 1 hour, and say what percentage of the work was being done by the machine and what was being done by the patient. I can also look at breath by breath, because just because 80% of it was being done by the patient, that other 20%, was it done all at one time, like the patient quit breathing altogether? Because some of your patients are going to do that. Call it periodic breathing. They will breathe for a while and then they stop. In Cheyne-Stokes breathing, they do that about every 30 seconds. They stop for 10 or 20. So you're counting the respirations, watching 1, 2, 3, 4, 5, 6. And they do nothing for about 10 to as many as 20 seconds. And then they, I'll breathe again. I want to know that, because before I take them off and say, oh yeah, doc, he can come off. He's doing 90% of the, he's doing 80% of the work. Yeah, he does. He does 100% for 80% of the time. 20% of the time doesn't breathe at all. Well, I need to know that. So I can look at the trend data. That way I don't have to be there all the time, and it tells me what happened in the past. It also tells me if somebody's changed my dials. Was there an alarm while I was gone? Nurses call and say, oh, it was alarming, I reset it. I need to know what was alarming. I can go back in and say I want alarm history, and bingo, I've got the alarm history. I know exactly what time it was, what took place, and I can then correct the situation. But we'll be working with all of these. But this is how we use pressure volume curves, compliance, resistance, because if my patient's compliance changes, I need to know about it. How am I going to assess it? If the patient's going to congestive heart failure, the compliance gets worse. If their pulmonary edema is getting worse, the compliance is going to get worse. If they blow a pneumothorax, one lung is going to get real bad. And compliance is suddenly going to get worse. Because now they only have one lung working, and it's eventually going to collapse the other lung. And then I set off the alarms again. And you get used to your alarms too. As I said, we'll be working with all of these, and you get to know these two. These two here both talk. They bite.
They bite?
I can make them bite.
That's hella creepy.
So whenever the students start to think, you know, I'm
It's
really
like
good
Chucky
at
creepy.
intubating or something like that, and they go slide it in, you down they go.
What?
That's gonna be scary, Mr.
You can also
Dyer.
make their vocal cords close, so you can get in there, you're looking at them, and say, I'm ready to put the tube in, all of a sudden the cords go boom and
Nice.
close. But they do talk to you. They have over 1,500 different cardiac arrhythmias that we can give them. They have breath sounds. They have bowel sounds.
This one over here doesn't look too hot.
No, he's had a few
War
problems.
veteran.
He can pop a pneumo. Either one of them can. We can have them. They have femoral pulses, pedal pulses, posttibial pulses. They have carotid pulses.
Do we do arterials out of them? I was just checking to see if they had any marks in them.
We don't use them for the arterials. We have 2 others, or actually 4 others.
So you just
We
have
use-
arms, right?
Yeah, we
They
use
use the
arms to do
junkies.
brachials. Yeah. These do have pulses, blood pressures, so that we'll simulate various diseases, arrhythmias with it. And when that happens, also the blood pressure changes. And if your blood pressure drops suddenly, you lose it on the radial, but you've got it in the femoral, you've got it in carotid still. It has heart tones. You can get over, I think there's about 25 different heart sounds, murmurs and so forth that will simulate different, whether it's right, left, mitral, aortic, different gallops and so forth. So they'll stick out their tongue too. It's like they'll throw up.
That's nice.
We don't use some of the functions with them. For instance, they do have bladders, and they can be filled so that they also will urinate. And yeah, we do. We're working on getting the infant ones, but as I said, the infant ones then will stimulate all the cardiac anomalies. They have a birthing one that actually gives birth.
Oh, that's nice.
Oh, that would be
Weird.
sick. We gotta get that shit.
But here you're going to be doing your patient assessments. You're going to be taking pulse oximetry.
What is that hanging out of her mouth?
Oh, these are ET tubes. They intubated them
Oh.
earlier today. So, and then we can hook them up to the ventilators too. But
I thought the tubes were bigger.
huh? Yeah, these are small ones. They're going to put like 7 O's and 7 fives.
Yeah.
these are 7 fives.
That's what we do in Mod 4, right?
Yeah. Next term you guys.
Oh, 3?
Yeah, our class is doing this. That's probably
They
who
just
did
found
it.
out where they're going for their rotations too.
Yep.
2 of them staying at my house had to move to Sonora.
Yes. Alrighty. Well, we'll go back, open up the door so you guys can get your stuff.
Thank you, this was awesome.
Yeah, interesting stuff, huh?
This is the patient assessment, all your breath sounds. Blood draws.